Good morning, good afternoon, and good evening, everyone. Welcome to Building Transnational Solidarity and Targeted Action for Equity in Health, Bridging the Gap on Maternal Health for Women and Girls of African Descent. This event is co-organized by the UN Population Fund, the Pan American Health Organization, and the Universal Access Project at the United Nations Foundation, and co-sponsored by the governments of the United States of America, Brazil, Costa Rica, Luxembourg, Mexico, and Suriname. We are so delighted that you are joining us both here in person and online at the margins of the Summit on the Future and the high-level week of the UN General Assembly that will bring together world leaders in New York to forge new international consensus on how we deliver a better present and safeguard the future. Ladies and gentlemen, my name is Melissa Noel. I'm a multimedia journalist and contributing news and politics editor at Essence magazine. At Essence, I produce social justice, race, culture, Caribbean and global African diasporic content across company platforms. And I am also the founder and chief creative officer of Melanin Media, a consulting firm that specializes in strategic communications and storytelling for multicultural audiences in the US and the Caribbean. I am deeply humbled and honored to be invited to participate as your MC and host today, especially as a Black woman and a reporter who regularly covers issues that are impacting Black women, and particularly maternal health. This event is available in English, Spanish, and Portuguese. For those who are joining us via Zoom, please take a moment to choose your preferred language from the globe icon at the bottom of your screen. Give folks a little second to do that. And for those of us joining us right here in the room, a receiver was placed on your seat. Please set the channel for Spanish, Portuguese, or English. And let's take a moment now. If you have not received one, please raise your hand and someone will bring a receiver to you. So I want to take a moment. I see several hands going up. We have an amazing program planned for you, so let's get started. Now, to kick off this event, I want to welcome Ms. Diane Keita, the Deputy Executive Director of Programs at UNFPA, to deliver our welcoming remarks.
Buen día. Buenos días. Excellencies, esteemed colleagues, dear partner and friend, Madam Moderator. I am honored to welcome you all at UNFPA headquarters for today's exciting event to launch the Global Coalition for Transnational Solidarity and Action to bridge the gap in maternal health for women and girls of African descent. I would like also to extend UNFPA's gratitude to the Pan American Health Organization, PAHO, and the Universal Access Project at the United Nations Foundation for their invaluable partnership, and to our event co-sponsors, the government of Brazil, Colombia, Costa Rica, Luxembourg, Mexico, and Suriname for their commitment to this agenda. Our appreciation also goes to the government of Luxembourg for their steadfast support to UNFPA's effort in this important area of work. Dear friends, 30 years ago, the landmark International Conference on Population and Development, ICPD, set a bold agenda with world leaders unanimously committing to place sexual and reproductive health and reproductive rights for all at the core of sustainable development. Today, we have so much to celebrate. More people than ever before are exercising their essential life-sustaining rights, including the right to health, to safe pregnancy and childbirth, to contraception, and to protection from gender-based violence. Yet, for millions, including women and girls of African descent, these rights remain intangible. To better understand these disparities, in 2023, UNFPA and its partners conducted an analysis of maternal health among women and girls of African descent in the Americas. The analysis revealed alarmingly high maternal death rates among Afrodescendant, both in absolute terms and in comparison to non-Afrodescendant and non-Indigenous women in the region. Women of African descent were found to be up to 3 times more likely to die from preventable maternal death causes, and this must change. These disparities persist even when accounting for social determinants like socioeconomic status and education. Systemic and structural racism and sexism are significant drivers for these shocking maternal health disparities, and they are impeding Afro-descendant women and girls from realizing their rights to access the highest attainable standards of care. The lack of culturally relevant healthcare approaches, coupled with insufficient disaggregated data, further deepens disparities, making it challenging to address the unique of Afro-descendant women and girls. Currently, only 11 out of 35 countries in the Americas collect maternal health data broken down by race. And only 4 of these countries provide data on maternal death by race. We commend the countries already disaggregating data for their effort, as we cannot address what we do not measure. Clearly, we need more partnership, more investment, more coordination, and greater political will. And we need it fast, we need it now. We can all agree that no woman should die while bringing life into the world. Together, we can work to remove barriers to care, ensuring that every woman and girl, without exception and without discrimination, can access the care she needs to lead a healthy and dignified life of right, justice, and choices. Dear friends, central to our strategy for people of African descent is our partnership with local, regional, and global stakeholders. You all collaborating to counteract systemic racism and sexism as pivotal social and structural determinant of health, including maternal health. This involves supporting the design and implementation of targeted policies and programs with the meaningful participation of the communities, ensuring their values and needs are fully acknowledged and incorporated. It means enhancing communication and strengthening strategic partnership to develop disaggregated data and evidence to not only monitor progress, but to actually drive progress. Our executive director, Dr. Natalia Kanem, frequently raises that maternal mortality is the canary in the coal mine when it comes to measuring the equity and functioning of health systems and societies. It is well and truly time for us to hear this canary's warning. I look forward to today's exchanges on the way to bridge the maternal health gap and increase global solidarity and commitment to equity for women and girls of African descent. I thank you all for your kind attention and for being here today with us. We are grateful to you for this partnership towards a more equitable and just future for women and girls around the world. Muchísimas gracias.
Thank you so much, Ms. Keita, for your remarks and providing such insights into the state of maternal health today, including those really stark statistics that I often stop and think about, that they're not just statistics, these are people's stories, and they're living these realities every day. So this is really, really an important time to have these conversations. Thank you for also highlighting the persistent disparities faced by women and girls of African descent, and knowing that their stories matter. I will now invite our next speaker, Dr. Jerry Eckermans, Director of Social and Environmental Detriments for Health Equity at the Pan American Health Organization, to deliver remarks.
Good morning, buenos dias, bon dia, goedemorgen. Distinguished ambassadors, country delegates, esteemed panelists, colleagues, participants, friends, all. On behalf of the Pan American Health Organization, PAHO, and our director, Dr. Jarbas Barbosa, I'm honored to be here to address a topic of immense importance for the region of the Americas and the world. First, I would like to extend my gratitude to my distinguished co-organizers, Ms. Yang Keita, Deputy Executive Director of UNFPA, and Ms. Deli Severin, Executive Director of the Universal Access Project at the UN Foundation, but of course, also all the others that are going to speak. In 2020, a maternal death occurred every hour in Latin America and the Caribbean. Every hour. That same year, the region's maternal mortality rate regressed to the levels that we saw 20 years ago. And this is not a statistic as we just heard. These are women, and these are women of African descent, indigenous women, and those living in vulnerable conditions. These are the ones that lost their lives by giving life. This is unacceptable. The number of maternal deaths is inconsistent with the level of development of the Americas, as was highlighted by our director when he launched our new strategy to accelerate the reduction of maternal mortality in the region of the Americas, based on primary health care. To support and to implement this effort, the Pan American Health Organization is establishing a strategic advisory group of experts on maternal mortality, comprised by those senior experts who will provide strategic guidance to enhance the acceleration of the response. And we're also setting up an advisory group on health equity. We need an equity approach in our health systems, one that integrates gender, human rights, economic empowerment, and cultural diversity, and that focuses on addressing the social determinants of health to improve access to health, including access to healthcare, to close those persistent gaps. The Americas is the most unequal region in the world, and the COVID pandemic has deepened even more these inequities. And this is particularly affecting people of African descent, particularly women, those that were already left behind, rooted in historical injustices and racism and ongoing discrimination. PAHO recognized that addressing these inequities demand a comprehensive and culturally sensitive approach. Our Department for Social and Environmental Determinants for Health Equity works across sectors to reduce health inequities, embedding human rights, gender equality, and cultural diversity, health equity into the public health agenda. And in this context, PAHO's policy on ethnicity and health, that was already unanimously approved by our member states in 2017, offers a strong framework to ensure an intercultural approach to health and equitable treatment for people of African descent and other ethnic groups. And while there is progress, significant progress, there are many, many challenges that persist. Bridging the health and well-being gap for women and girls of African descent requires coordinated intersectoral action, requires effective participation, and requires solidarity at all levels. And this is required for all of us, It means that we all need to work, government, civil society organizations, community leaders, international organizations, funders, all working together towards this health equity. Strategic partnerships are critical to effective policy making, as fragmented efforts weaken advocacy and undermine progress. There's much work ahead. PAHO stands ready to work hand in hand with all of you to contribute to the empowerment and the protection of every woman, every girl, and to ensure the right to health for all. Thank you.
Thank you so much for bringing into focus and highlighting the important work of the Pan American Health Organization. And also, again, just really driving home that those statistics are not just statistics, that these are people's stories. It was really difficult to hear that there's a maternal death once per hour in Latin America and the Caribbean, and for bringing light to the fact that, it is really, really stark that this is happening in 2024. So I thank you for that. And I'm gonna keep reminding, everyone of these stories, right? As we move along in the program. Next, I'd like to invite our next speaker, Ms. Dilly Severin, Executive Director of Universal Access Project at the UN Foundation.
Hello, everyone. Thank you, Jenny. Thank you, Jerry, for those remarks and for helping to set the context for our important discussion today. I'm Dilly Severin, Executive Director at the Universal Access Project at the UN Foundation, and it's really a privilege to be with you here today. Special thanks to our colleagues at UNFPA and PAHO for your collaboration in bringing this to life. And of course, special thank you to our representatives from Brazil, Colombia, Costa Rica, Luxembourg, Mexico, Suriname, and the United States for your support of this work. We know that this is an important year to accelerate action on sexual and reproductive health, rights, and justice. It's not only the 30th anniversary of the ICPD Program of Action, it's also the 30th anniversary of the reproductive justice movement. And with the Summit of the Future just around the corner, it really is a unique opportunity to coalesce around a blueprint for the future, one that puts every person in the driver's seat of their own bodies, lives, and futures. And like my colleagues have been saying, there has been so much progress, but we also have a road ahead of us. And we know that this is especially evident when we look at maternal mortality and morbidity, both globally and in the Americas. It's even more stark, of course, when we look at the experiences of Black women. We know that no matter where they are in the world, Black women are bearing the burden of maternal mortality and morbidity. For me, in the US right now, reading this week stories about Amber Nicole Thurman, this morning, seeing the ProPublica pieces on Candy Miller, which are highlighting how their deaths are a direct result of an abortion ban denying essential health care. The challenge in front of us is quite stark. We know that there is an undeniable gap in health equity and care, and especially for women and girls of African descent. So today we'll hear from experts across sectors and geographies about how we can work together to bridge this gap. We know that everyone in this room is essential to fulfilling the promise of ICPD and the reproductive justice movement. We do need transnational partnership now to leverage all of our unique roles and to deliver life-saving results for women and girls of African descent in all of their diversity. Now is the time really to put our words into action and our action into overdrive to make sure the promise of ICPD is fulfilled for all and not just for some. We cannot wait another 30 years. So thank you all.
Thank you so much, Ms. Severin. And as you said, the time is now. We cannot wait another 30 years. So now I have the pleasure of helping us transition to our first moderated panel discussion of the morning. I invite the panelists for the first conversation to join me here on stage. Our first panel is titled Health, Equity, and Ethnicity, promoting social participation to improve the health and well-being of women of African descent. We are very honored to have Dr. June Suma, Chair of the Permanent Forum on People of African Descent, to moderate this panel. Dr. Suma, the floor is yours.
Thank you very much. I would like to start by thanking the organizers, especially UNFPA, PAO, and the UN Foundation for making sure that I got here. And I am the chair of the Permanent Forum of People of African Descent, but I am also a historian. And it is from this context that I will start my presentation to you and introduce the panelists to you. To say that I am very passionate about this issue with regard to the subject of women and girls of African descent, especially on this occasion, the health of women and girls of African descent. And because the first panel will be setting the tone for you, I thought you should know that I'm also a very passionate historian. And that, thank you, and that I want you to know that much of the terrorism exacted against Black bodies during enslavement was directed at the Black female body. African women were portrayed as promiscuous, uncivilized, and immoral as justification for their exploitation. And so I have written quite a bit on it, and in one of my writings, I noted that there was a systematic approach of dehumanization of African women, which started in the 17th century, and which set the tone for the continued devaluation of women of African descent to this day. This image has perpetuated the abuse of the Black female body while attributing the blame on the victims. Which is why I advocate passionately also for reparations for women of African descent. And that must be taken into consideration when we look at bridging the gap on maternal health and for women of African descent, for women and girls of African descent. And the treatment of women of African descent in the area of health care, especially with regard to maternal health and the treatment of their babies, is not something in the past. It is something in living memory. And it continues to be the reality in many countries today. I want you to know that there were experiments conducted on the Black female body, which today still says that Black women don't experience pain. And so you understand the issues around maternal health when you come to the table with that ideology, or to the maternal bed with that ideology. And so for me, because I'm also from the Caribbean, it's interesting because right now in the Caribbean, we are all governed by people of African descent, yet the disparities that exist in our countries because of poverty and lack of access to health for women of African descent in the Caribbean is alarming. I mean, poverty rates for us in the Caribbean, for women, and the first set of people to lose jobs is about 30%. And so you know that there is no access because of these disparities, and not just access to health, but to other socioeconomic conditions that would make it possible for us to access the kind of health that would take us away from that gap or help us to close that gap. And so I think many things have to be done, and I hope that my panelists will be addressing some of these issues today. If not, you can be sure that I will at some point address them also. And so let me introduce you to my panelists. Carmen Correa, who is, and her bio is going to be up, but tremendous with regard to financial inclusion in the area of health and education, and works with low-income women across Latin America. So she brings the resources, so she gives a little more access. And she will be speaking to us today with regard to considering the health disparities faced by women from from African descent and taken into account Pro Mujer's work and experience at the community level for over 30 years, and in recent years, incorporating digital technologies to your programs? What strategies do you implement to address these inequalities and promote their health and well-being? My second panelist, very interesting to me, because she is a postpartum doula and medical anthropologist. And she has been working in this area to make sure, and through maternal health research, she has been trying to make sure that women also have access to better birthing and facilities, etc. And I wanted to concentrate on how do your organizations, because she has more than one, how do your organizations create solution-based strategies to promote empowerment and support overall well-being, particularly mental health for women, birthing people and their families? She works at the level of the family. And then there's Linda Gola Blout, who is the president and CEO of Black Women's Health Imperative. And she has been doing that for over the last 10 years. And so because of her work with the public, the private and nonprofit sectors, I want her to address the strategies with regard to critical health issues such as diabetes, hypertension, cancers, and all of these things have their roots in enslavement and gender-based violence that affect the health and well-being of women of African descent, and which strategies does your organization promote to improve maternal health of women with those chronic diseases or conditions? Now, each of my panelists only have 5 minutes. So you can be sure that they will be giving you focused work, and I look forward to their presentations. I start. I won't come back, so just go ahead. Okay. I'll let you speak.
Thank you. Thank you very much, Dr. June Sumer. It's a pleasure to be here this morning. Thank you very much to PAHO for this invitation, UNFPA for inviting me to be here participating in this relevant conversation. Basically, Pro Mujer is an organization that has been working in Latin America for 3 decades, as it was stated before, taking and helping women across the region actually to achieve their full potential. We believe that if we give women the right resources, the right services, we provide them with access to those services they need to improve their quality of life, they will become agents of change. And basically becoming agents of change, they will generate a big change, not only for themselves, but for their families and for the community. And without a doubt, for women to reach this point, we need to provide comprehensive solutions. So that is why we provide a holistic approach to women. For us, it's not only giving access to financial services or health services or education. We need to understand the needs of those women, and we need to understand the intersectionality, because we don't have one woman that is the same as the other one. They live in rural areas, they could be living in urban areas, they could have a different gender. So we have to really understand their needs. We have to really understand what is going on in their life. And with that, we will develop the right solutions and the appropriate products and services. So this has been key because racial identity greatly shapes the experience of being a woman. And it was stated before with some numbers, but for example, in terms of health, we estimate that basically ethnically, marginalized women are 3.5 times more likely to die from pregnancy or childbirth complications. This is stated by PAHO. This is one number. This is one statistic, but the numbers are really showing us the barriers that we have to face when we talk about racialized women, and we must have the sensitivity to understand what's going on out there and to really take care of those women and to really develop the products and services they need. This is what we are trying to do. In that sense, I would like to say that all the initiatives we are implementing at ProMujer from the very beginning are kind of designed, whether if they are digital product services that we provide or in-person services that we provide, the services we provide try to incorporate a diversity perspective. And we try to really understand what allows women to actually achieve their full potential. And with that is what we bring into the community. So each group of women basically we serve is really kind of finding out what is going on at their level, what is going on at their community, what is going on in their families, and with that, we provide a service. For example, throughout our training platform, Emprende ProMujer, we have impacted more than 4,000 Afrodescendent women, particularly from Colombia, Venezuela, and Mexico. Not only we offer them training courses through the platform to strengthen their leadership and personal development skills, but also to acquire those financial, digital, and business skills they need to boost their enterprises. But through this platform, also women have access to content about the importance of self-care, promoting culture of preventive, and among other things that are needed. Additionally, we have developed 3 preventive health chatbots available to all women at the regional level. One is around breast cancer, the other is around diabetes, and the third one is sexual and reproductive health. And through this later, we are actively contributing to reduce maternal mortality, teenage pregnancy, and the extremely high rates of deaths from cervical cancer. So we are strongly focused on working directly with Indigenous women who represent a large group in the region, but of course we are open to be working with all women in Latin America. So with that, I will try to finish in my presentation stating that we are very happy. We are going to be signing basically a memorandum of understanding with PAHO. We are going to try to be working together in Latin America around these themes and others. I think, as you stated before, that we need to be collaborating much more among all the organizations working, in this case, in Latin America. Thank you so much.
Greetings, everyone. Okay. My name is Emily Rodriguez. I'm really happy to be here with you all. 10 years ago, I started Ashe Birthing Services, which is a team of 15 Black and Brown doulas based out of the Bronx that serve about 400 families. Yes, that serve about 400 families a year in New York City. For those who don't know what a doula is, we are non-medical providers that offer physical, mental, emotional, informational, and sometimes spiritual support to birthing people and their families during pregnancy, birth, and postpartum. Doulas are an intervention. We don't usually think of us that way, but we are. We help families know their options, advocate for what they want, and help them set up to succeed. With doula support, studies have shown we decrease the length of labor by 25%, cesareans by 50%, the use of Pitocin by 40%, and the request of an epidural by 60%. Society tells us, yes, thank you. Society tells us that the only goal of labor and delivery is a healthy mom and baby, but it's important how the mom feels afterwards. Were they listened to? Do they feel respected? Were they empowered to play an active role in their decision-making process, et cetera? Doulas also play an invaluable role filling in gaps in our healthcare system. When people are discharged from the hospital, they're discharged to no one. Doulas mother the mother. We care for them after birth so they can take care of their baby. Research shows that doula support also lowers postpartum depression and anxiety by 58%. While doulas make huge impacts on families, I wanted to also address, like Dr. June said, the root cause of the state of maternal health in the United States. When we look at the start of obstetrics, here in the non-consensual experimentation of enslaved Black people, Black women without anesthetic, we can see how a lot of racism still prevails in the institutions and systems that were never created with us in mind. We created the Bridge Directory to heal those disparities in greater scale by training institutions and providers, redefining expectations in care, and closing the access gap. We're a free resource to find perinatal providers of color near you, starting with New York City and New York State. A birthing person can look for a midwife or a mental health therapist, for example, who speaks Creole and takes your insurance, and find a condensed list of vetted providers who have agreed to our standards of care and model of care. We are also focusing on scalable multi-level strategies grounded in anti-racism and patient empowerment. We're currently working on a 7-year grant with Columbia University funded by the NIH to create a maternal health research center of excellence in New York City, training researchers, providers, and patients in a bi-directional approach. We don't have the luxury of waiting for change. We have to create it. We need to create bridges. We all of us are seeing holes and come up with solutions to fix them one family at a time. Thank you.
Good morning. As Dr. Sumer said, I'm Linda Goler-Blount, president of the Black Women's Health Imperative and chair of the Rare Disease Diversity Coalition. And the Black Women's Health Imperative last year celebrated its 40th anniversary of being the only national organization in the US focused solely on the comprehensive health care of Black women and girls. And I don't know if you all are surprised, but one would think that in the United States, there would be more than one national organization with that focus. There are lots of organizations doing great work, but surely Black women deserve more than one national comprehensive organization. So we work with many, and we spend a lot of time talking about the issues of Black women's health, obviously, and you all are familiar with the social determinants of health. But our burning question is, why do the social determinants of health exist in the first place? So we've heard these terrible statistics of Black maternal mortality being 3 times that of white women. In Washington, D.C., it's 5 to 6 times. We've heard breast cancer mortality, 42% more among Black women as compared to white women. But the thing I want to say is it's not because they're Black. This is the way public health people and medical professions talk about it. They would lead the listener to believe it's because they're Black. It's because of the lived experiences of being Black in this country. And what we see is when Black women, women from the diaspora, come to the US, with each successive generation, it gets worse. So if you're a recent immigrant, you may have wonderful statistics and outcomes, but by the time your grandchildren are around, you're just as you're in the same situation as Black Americans. And we can trace all of this back, obviously, to the roots of that you've heard of enslavement. But I want to sort of put this in a bit of context. Black women have 15% more cortisol, a stress hormone, in their bloodstreams as compared to white women. So if you look at some of the research, Fleda Mass-Jackson found a causal relationship between experiences of racism and low birth weight babies. Arlene Geronimus talked about weathering 30 years ago. Black women literally are aging faster than white women. Tanae Lewis, who's a researcher at Emory, has found a causal relationship between what's happening, fraying of telomeres in the DNA, and hypertension, obesity, cardiovascular disease, obesity-related syndromes because of the changes in metabolic and inflammatory responses. And the Black Women's Health Study, whom we partnered with a few years ago, has looked at diet and obesity. If you give Black women and white women the same high-fat diet, Black women will gain more weight and gain it faster. If you give us the same low-fat diet, we'll lose less weight and lose it more slowly. And yet physicians and medical professionals blame Black women. These are what we take into our pre-pregnancy health conditions, our lived experiences, and that's what we see. So if we look at the effects on Black women's bodies, what we see is the issue is access. It's not biology, it's not genetics, it's what we have access to. And just a quick example, in 1982, breast cancer incidence and mortality rates were exactly the same between Black women and white women. Now we talk about this 42% difference. It reflects only who got access to early detection and quality treatment and who didn't. And that persists today. These are systemic issues, and the system benefits the people who designed it. So what we all have to do, and what you've heard from my colleagues here, is we've got to change the system. Yes, we need wonderful programs like doula programs. We need the kinds of work that's happening in Latin America, but we've got to change the system. So what the Black Women's Health Imperative is focused on is just that. We've got wonderful programs. We've got a lifestyle change program, which is a Centers for Disease Control funded program to prevent diabetes and chronic disease. It is the top performing program in the country. We need to take that to scale. But again, we're sort of putting the responsibility on Black women and their families. Black women are doing what they're supposed to do. We also have a doula program, and I'm going to talk to you more about that. We graduated more than 30 doulas proven to protect moms. And we've got a young women's program that looks at preconception health and what we bring into our pregnancy. Half of incoming freshmen at HBCUs are pre-diabetic and pre-hypertensive. So we're looking at 3 areas. One is quality measures. If we change systems and policies, I'm telling you, I think if providers and healthcare system leaders thought that they weren't going to be reimbursed every time they ignored a Black woman and she died, they'd figure out a way to listen to her. So we're working on ensuring that there are quality measures for Black women's health, for maternal outcomes and chronic disease outcomes. And we're also supporting the Medicaid program. It is now finally expanded to cover postpartum up to a year in all but 4 states. So our next frontier is to make sure there's full coverage. Almost 40% of babies are covered under this insurance program, to make sure all moms and their families are covered. So it will take that systemic approach. I thank you very much for your attention.
I would like to thank all of the panelists for their insights and the work that they're doing on the groundwork. We will now start taking questions. We will start with one from the audience, and then we will move on to the, yes, we have one right here. We'll move
Good
online.
morning. Thank you so much.
And
Anna Barreto.
can you direct your question?
Absolutely.
Thanks.
Anna Barreto from Planned Parenthood Global. My question to Linda and Emily, because you are both working in the US, and I think that is very key for us to understand racism as a system of domination, but also understand that in a capitalist society, money is what drives us, and also is the main determinant of quality of life and sometimes dignity. So my question is how your work is related to universal health care in the country, like in the United States.
Related to what?
Universal health care, so free healthcare, let me put it that way. Thank you.
Thank you. And briefly answer. You do have a mic next to you, so you don't have to get up and walk.
So
Press it.
just briefly, I mean, access is everything, to your point. And so what we spend a lot of time doing, and we spend a lot of time in Washington, D.C., and I've just this summer met with over 16 people in the Senate and Congress, is to talk about the connection between access and health outcomes and economic outcomes. So to your point, free healthcare would be wonderful. I think in this country, that's a bit of a stretch, but complete access is possible. And so we make the business case as well as the health case for that.
I just also want to add that we have to get creative with solutions. You know, at Ashe, for example, we barter. We're claiming a lot of things that have worked for us. You know, we're never turning away people. And so that includes sliding scale, that includes hustling for grants like we're all doing, and, you know, and bartering as well.
Thank you very much. Another question? We have a hand up over here.
Thank you. Good morning. My name is Marilena John, and I work with UN Women. I have a question for the panel in general. Anyone can take it or all. We spoke a lot about the system and about concrete things that we're doing to change the system. I wondered if there's any thought given to a particular, the aspect of self-empowerment within communities, and the importance, and education too, and the importance of using creativity in moving the needle on the kinds of deep-seated harmful social norms and stereotypes which drive things like racism and gender inequality. If any of this is incorporated in the work, both in terms of working with the people affected, women of African descent, as well as those in the system and larger processes as well, perhaps campaigns that are targeted, but that are targeted using creativity, the work of artists, and, you know, the whole spectrum, including comedians, for example, everything. Thank you.
You can start.
Okay. And basically, we have seen in the communities we have been working, what we have seen is that there are tons of leaders at the community level. So what we try is to empower them, to give them the power to become really leaders in their community and to have a voice. And of course, as you were sharing, I think that if we innovate on how we can train or how we can actually use certain arts or different ways of promoting that, that is something that, of course, from ProMujer, we are trying to use different methodologies. But I think that if we want to change the system, when we talk about the system itself, beyond giving these women at the community level visibility and the power to have that leadership, we also need organizations such as UN Women and others to advocate for that change in the system. I think that is a role that organizations such as UN Women should play.
Thank you for that. I agree with you. We have to take all avenues, and art is really important. This past spring, we released a documentary called Me Period, which won at Essence. Thank you very much. But it uses humor as well as influencers to talk about the story of getting your first period. It's mothers and daughters talking, but there's also a lot of pain in that. But we didn't want to just make it that. So we used humor and used kind of the real stories to help women understand what they can do, but also for policymakers. I live in Georgia. Menstrual products are taxed as luxury good items. So we can use these stories to change policy.
You have an answer?
We also have participated in other documentaries similar to what Linda has shared. There's one that I'm really excited about called The Ebony Canal that follows the journey of 4 moms who have lost babies early on in Pittsburgh. And then there's an illustrative film called The Impossible Journey that just won 2 Cannes Awards. And it also takes us along this journey of 2 similar people that just have different colored skin and their different experiences. So I think art is absolutely a method to communicate our goals and reproductive justice.
Thank you. No? Just a follow-up to that question I have for the panelists, and I'm sure it's one that all of you all want to know. We have spoken so far a lot on the victims, women and girls of African descent. what are we doing with regard to the victimizers, the structures, the hospitals, the doctors, and so on? What are we doing? I mean, are your organizations in any way engaged in changing minds? That's the only way you can change the system, if you change the minds. Are you doing anything in that regard?
Yes, from our side, we are training doctors on gender-based violence. So in order to revert that type of conduct during any screening that you will request from them.
And again, we are coming at this from a policy perspective. We are making clear what happens to women, their families, communities, to the economies when Black women don't have access. And so they understand we're not to blame. It's the system working against us, and we're showing them how they actually benefit. And it's not our job to make money for corporate America, of course, but we keep reminding them the demographics of the US and in fact, the globe are changing. And if they don't figure that out and figure out how to value Black women's health, then they get left behind.
Yes.
One of our pillars at the Bridge Directory and our model of care is accountability. There is very little accountability within institutions, the medical institution. And so we go in our training programs and retrain and hold them accountable. And right now that looks like actually putting up individual statistics of each provider. It's like if we can internally, it doesn't have to be public, but internally say, this provider is still doing episiotomies at 80%, even though that's no longer recommended. What's going on there, and create pressure within the system to change it.
Yes, I hope you are being impactful there. We have a question here. Yes? She will give you the mic.
Thank you all for your contribution. I think what you all are doing is really life-changing to a lot of people on the ground level. My question is, I'm Priestley Johnson. I work for Girl Up USA, and girls around the world are very much aware of what happens later in life, and they come to us with like very much a gusto for wanting to change the system, how to get more involved, what can we do to make sure that this current society is not the society that they grow up in and then become victims of. So I guess my question for the panel is, what can a young person do to get more involved in this and make sure that they are positioning themselves for a better society?
Okay. Can we start with Emily?
I think it's really important that they equip themselves with information that they can grow up with and feel empowered, so that they're not giving their power away when they walk into the doctor's office or the hospital system. We have to really center hope in this conversation. These conversations can feel really discouraging, and like what can we do to make a significant difference? But I think it absolutely starts with ourselves.
I would love to talk to you. And we have a program called My Sister's Keeper, which is all about leadership and advocacy skills, understanding policy and health and the connection between the two. And so that might be a great place to start.
I totally agree. I think that everybody needs to understand how to navigate the different health system. That is something that we look very much forward. We are always trying to get that type of information to all women around us. So that is basically what we do.
Thank you very much. Unfortunately, we don't have any more time for questions. Feel free to meet the panelists afterwards and speak with them. But I will give the panelists 1 minute to say whatever you think is very important, especially if it's an actionable item.
I don't think I have much to add, other than what I just shared about really centering hope and empowering ourselves and our communities and being active participants in our healthcare and the health of all of us.
Thank you.
And I would say, as much as we want people to do things because they're the right thing to do, that doesn't seem to be terribly motivating for our leaders. So we have to legislate the behavior change that we need and make it clear when that behavior is not happening publicly, early, and often.
Thank you.
One word, intersectionality. I think we need to understand that that is out there. Thanks.
On your behalf, I would like to thank the panelists. I think we had a very great discussion. As I said, feel free to meet them. I am very proud of the underground work that each of these women are undertaking, the fact that they meet you at the individual level. Very important for this gap to be bridged. So thank you very much to the panelists again.
Thank you so much, Dr. Suma. That was quite an informative discussion highlighting the importance of, as we heard, intersectionality, action, and the ability to really meet people where they are. So right now I want to invite the panelists for our second panel titled Bridging the Gap in Quality Maternal Health for Women and Girls of African Descent. It is my esteemed honor to welcome Aisha Cisse, UNFPA Goodwill Ambassador, award-winning journalist, and CEO of Araya Media, to guide this important conversation. I invite the second panel to join me here on stage, and Aisha, the floor is yours. Welcome them, everyone, welcome.
We're going to do things a little differently. We're going to remain seated. So first off, let me say, excellencies, esteemed partners, panelists, ladies and gentlemen, good morning. I'm going to lift this up. It is so good to be with you. It is actually an honor to be part of this conversation, and I'm thrilled that I'm here. And I want to thank you and the previous speakers for being present, fully present for this really important session, these critical conversations. Before we get going, I really want to ground the conversation we're about to have. As we've already said, this conversation is about bridging the gap in quality maternal health for women and girls of African descent. We are so fortunate to be joined by three incredible women here on stage who are doing change-making work to change outcomes for Afro-descendant women and girls when it comes to maternal health. Let me introduce them. I'm not going to go through their bios because they'll be up on screens. I'm just going to give names and titles. Monica Simpson, Executive Director, Sister Song US. Please make them feel welcome. Tiani Palmer, midwife, obstetric nurse, Costa Rica, based in Costa Rica. Please welcome her. And at the end there, but by no means last, Carleen Wilson-Mitchell, Associate Professor, Midwifery, Toronto Metropolitan University. So here's the thing. I've been a journalist for a very long time. I have long been aware of the data points around maternal health and the disparity in outcomes for Black women. I know the statistics, I'd read them, I'd reported on them. I knew that we're 3 to 4 times more likely to die from maternal related causes in childbirth than our white counterparts. But I didn't know. I didn't really understand until I gave birth to my daughter 18 months ago. We talk a lot about how it doesn't matter where you sit in society, social determinants, whether you're well educated or whether you have money, that the outcomes are affecting us across the board. I'd read that, but I didn't know. And I gave birth to my daughter, Naima, actually she's 19 months today, here in New York City. And I can speak to the deep understanding of how Afro-descendant women and girls feel utterly minimized, made to feel invisible, marginalized during the process of having their children. That's if you survive it at all. From my experiences in one of the top hospitals here in New York City, where I was being pressured to take an unnecessary and risky diagnostic test, because when they did the scan, my baby was small. And that conversation transitioning within breaths to, you should terminate this pregnancy, to giving birth to my daughter and being again in said hospital, and the postpartum nurse treating me with so much disrespect, refusing to listen to me as I talked about the pain I was in, acting with such annoyance that I was asking for more questions about the course of treatment I was being asked to take or being told to take. I will tell you this, I remember weeping in the hours that followed. And I had a doula, I had a tenured OBGYN in that hospital, and I still got appalling treatment. And I remember saying, because I made complaints and I was visited, and I said, I would not bring a dog to this hospital, let alone what you guys have put me through. So I now know, and I come to this conversation with that deep understanding of what women and girls of Afro descent right around the world are experiencing in different forms, and how we are utterly disregarded and our humanity is not seen. What I hope we'll get from this conversation are some concrete steps towards making a difference, that we will emerge from this conversation with concrete steps on how to bridge the gap and how to really accelerate and intensify the global solidarity, the solidarity we need to achieve the equity in this space. That's what I hope we'll get from this conversation. Let's jump in, shall we? I want to start with Monica Simpson. Monica, again, thank you so much for being with us. The reproductive justice movement marked its 30th anniversary this year, as we've said already this morning. And over the past 3 decades, it's played a crucial role in improving the lives of many of African descent in several different areas, but particularly maternal health. I really want you to speak to that incredible journey and discuss why global solidarity is a crucial component in achieving reproductive justice for women and girls of Afro descent.
Sure. Are you okay? Awesome. I'm gonna put this down. Yes. There we go. Thank you so much for, first of all, sharing your story with us to set the context for this panel. I know for us to share our stories that is a thing. And so I just want to acknowledge that you did something very bold and vulnerable in here this morning. So thank you. That's amazing. Thank you. Thank you so much for doing that and setting the context. But as a person, who was born and raised in the rural South, I'm a Black queer woman. This fight for bodily autonomy has been, my life's work, right? It's really, really important to me on so many different levels. And I'm really grateful that I get to be a part of this conversation today with folks who I look up to in the work that they do, but also to be able to just set a broader context to the understanding of reproductive justice in this moment and in this 30th anniversary year that we are celebrating as a movement. So I stand here in the legacy of the 12 Black women who came together 30 years ago to name and frame this movement of reproductive justice that gave us a more human rights-based, more intersectional framework to really address our reproductive lives in this country. This work was started in the midst of healthcare reform in this country, which is an important thing to note as we are talking about maternal health, and why it was important for us to think about broadening our perspective of our reproductive lives to not only include the human right to not have children and to prevent and end pregnancies with dignity and without shame, but to also include the human right to be able to have the children that we want in the ways that we want. And all that it took for us to be able to do that with the resources necessary and the social supports needed to be able to do that effectively, and to also to be able to parent our children in healthy and safe environments in this country. Because what does it mean for our children to get here and not have what they need to be able to thrive was also important for the founders of this work. And ultimately, we are talking about bodily autonomy. And we know that this is under attack in this country. It has been since the beginning of time in this country, because we can talk about colonization and slavery and all the things that contributed to that. But we do know that we are in a fight for our lives for bodily autonomy. And so for us to be able to take a moment to think about this journey of reproductive justice is really important to the moment that we're in when thinking about maternal health. So when I think about our journey as a movement and what we've had to do to really make it clear what reproductive justice is in a realm that was so heavily focused on reproductive health and rights as the only strategies, what is exciting is that this movement was created in a way that it was actually birthed out of a lot of the global solidarity work that was already going on, from Cairo to Beijing to all these different places where these founders were engaged. They were able to see that globally, women were already talking about their reproductive health and rights from a perspective of the very real social justice issues that they were having to interact with in their lives that impacted their decision making. And they wanted to bring that work to the domestic side of their lives, right? And so we already see a natural connection between the reproductive justice movement and global solidarity, even in its founding and how it was created. But when I think about where we are in this moment today, and we are in a fight for abortion access, right? And I think it's important to draw the connections into that. We already had folks uplift the names of Amber Thurman and Candy Miller, these Black women that have lost their lives in the state of Georgia because of this abortion ban. But what's real about that is that we knew that when we saw the attack on abortion start to rise decades ago, that whenever that happened, it was going to have a direct impact on maternal health care in this country. We knew that it was going to create even more barriers, even more of a strain on the lives of people in this country. And now we are seeing the impact of that with these Black women losing their lives, preventable deaths, right, in the state of Georgia. And even when we think about the maternal health crisis in this country, we have all the data and evidence to show us that it is also preventable in these ways. If Black women, if women were trusted, if parenting and pregnant people were trusted in their decision-making and listened to and heard. The other thing I want to uplift in this moment too, when I think about this journey that really got us to where we are around really deepening our work around maternal health care and RJ, when I think about how we really did go in on research in a really interesting way, and not from the typical way of doing research, but looking at like community-based participatory research methods, where we were able to really get to the stories of folks most impacted by these issues. When I tell you your story is unfortunately not unique. Like, we heard these stories so many times from women in Georgia, in Mississippi, and all of these places that really helped to build this data that said that Black women were dying at a rate higher than white women in childbirth. But it took us being able to go to people, to meet them where they are, to get these stories, to help us understand how to create the best policies and the best solutions to get people access to what they need. I'm really concerned about where we are in this moment in this country, right? I'm usually a very optimistic person. I believe that the power of the people always prevail. However, I'm really concerned about the fact that we are not seeing how these issues are inextricably linked to each other, which is creating not enough collective work and collective power for us to be able to move solutions together. So when I think about your last part of your question in regards to what is it going to take, or what's really exciting or necessary to think about global solidarity, is that we have to see that our liberation with each other is inextricably linked. And it only is going to take us working together across all of our different work, all of the different ways that we do this work, for us to actually see the results that we want. And as a person who's deeply committed to culture shift, I really appreciate the question about arts and culture and those innovative strategies, because what we are recognizing is that people they need ways to see themselves reflected. And if people can see themselves reflected, then that means they are then able to think about solutions for themselves, which then gives us the ability to move more policy solutions that are actually supported by people, right? Because you can't move policy if you can't shift the people. And so the way to shift the people is to make sure that they're seeing themselves reflected. And so we've been trying to do that in all of the innovative ways. A sister song from our Birth Justice Care Fund, Leah Jones is in the room and she can talk more about that. Y'all should hit her up and talk about how she's doing that. Thinking about the attacks on infertility or fertility justice in this country is real, with our Congress still pushing away in the ways that they are. So there's so many ways that we can really think about shifting the culture of these conversations, to destigmatize these conversations and to make sure that we are really pushing forward in a way that really brings everyone's voices to the table. So that's how I'm thinking about this work right now. And I'm excited to be in conversation with you all with questions after this.
Monica, thank you so much. That was phenomenal. And it's still resonating. Our liberation is inextricably linked. We know that, but we need to act on that. I want to transition to a perspective from Costa Rica now and bring in Siani Palmer, who's again, I'll say, is a midwife and an obstetric nurse. Siani, maternal health remains a significant challenge for women and girls of Afro descent, as we've said, right around the world. But Costa Rica is making some progress and is making strides in this regard. Can you talk to us about some of the successful policies, practices, and service delivery changes, if you will, that have resulted in this success? And also just speak to what are some of the remaining challenges.
Voy a hablar en español. Me disculpo, pero me es más cómodo. Como dijeron, yo soy enfermera obstetra. Soy de Costa Rica y trabajo en un área comunitaria, es decir, en un primer nivel de atención. Costa Rica como país, a diferencia de Estados Unidos, por lo que escucho, tiene quizás muchas coberturas en salud que permiten un acceso universal a la atención. Y eso también ha permitido a lo largo de los años poder disminuir en mucho lo que es la mortalidad materna en el país como un todo. Pero eso no significa que eso se ha logrado de forma uniforme para todos, como bien se sabe a nivel mundial. Pero dentro de las estrategias más recientes que hemos estado trabajando está el concepto de la erradicación de la violencia obstétrica en todo nuestro sistema de salud. Esa es una iniciativa que se lanzó hace poco, en julio, se hizo todos los lineamientos para poder tener políticas un poquito más claras para erradicar lo que es violencia obstétrica. Y cuando pensamos en violencia obstétrica, podríamos devolvernos a la experiencia que contó Aisha, de cómo vivió su parto, su transición. Lo que pasa con políticas como estas, a veces estas políticas no van pensadas en grupos étnicos, simplemente es una política nacional que en buena teoría engloba a todos, pero cuando tú vas hilando un poquito más fino podrías encontrar que hay igual desigualdad dentro de lo que se propone. También como país nosotros tenemos un tema de el acceso universal al parto, es decir, toda mujer embarazada, independientemente de su nacionalidad, tiene acceso a un parto hospitalizado con todos los derechos, pueda o no pagar. Eso es muy bueno. Pero si nos ubicamos en mujeres afrodescendientes o mujeres indígenas, ellas podrían no conocer todo ese derecho al que tienen y eso podría igual hacer que el acceso no sea tan oportuno como uno quisiera. También se ha estado trabajando políticas en torno a lo que es el parto respetado. Entonces, para hacer el parto respetado se ha estado creando toda una serie de capacitaciones que nos ha apoyado montones la Organización Panamericana de la Salud a través de muchos cursos para capacitar al personal. En el panel anterior hablaban de qué se está haciendo con el personal para cambiar esto, porque uno no puede cambiar únicamente pensando en la persona que recibe el parto, sino quién es la que la atiende o quién es el que participa. Entonces, como país se ha estado trabajando mucho con los que somos prestatarios de la salud para que la atención sea de una manera un poco más capacitada, pero de eso también podría decir, yo podría estar muy capacitada, pero no sensibilizada, y eso igual genera un bache en la atención. La capacitación debería ir de la mano con la sensibilización. Y para poder estar sensibles, para dar una atención, es vital entender las diferencias étnicas que hay en los grupos. En mi caso, que trabajo en un área de salud, eso me ha permitido acercarme a la comunidad y acercarme a la comunidad con ojos de afrodescendiente, no simplemente como una obstetra formada, porque sí es cierto, soy una obstetra formada para trabajar en un hospital o trabajar en donde sea, porque tengo una formación académica que me permite eso y 24 años de experiencia que me dice que sí se puede. Pero viendo nuestras prácticas hospitalarias, lo que se sabe o lo que yo he aprendido con el tiempo es, si yo estoy cerca de la comunidad, si estoy conociendo las necesidades de la comunidad, la atención varía. Y al variar esa atención, usted puede tener más acceso a esas mujeres. Esa mujer que está embarazada, que no quiere consultar porque no confía en el sistema, si tiene un prestatario de salud en el que confía, en el que conoce, va a ser mucho más fácil que se acerque cuando hay síntomas de alerta, porque muchas veces no se acercan teniendo signos de alarma. Y cuando llegan, ya llegan a morir porque ya vamos muy tarde. Entonces, dentro de las estrategias, y por lo que yo agradezco montones el trabajo que se ha hecho con UNFA en Costa Rica, es que ellos han estado trabajando a nivel local. ¿Cómo fortalecer y cómo tratar de que no queden personas atrás? Bueno, el sistema ofrece atención universal si usted sabe y puede accesar. El sistema está trabajando con capacitar al personal para que den una atención capacitada para poder disminuir este riesgo. El sistema está trabajando para erradicar violencia obstétrica, pero ¿quién entonces está en ese nivel local donde esas mujeres no conocen esos derechos y no se están acercando? Entonces, ¿qué han hecho ellos? Por ejemplo, fortalecer una clínica chiquitita en una comunidad específica donde hay mujeres que por situación socioeconómica no se acercarían a una clínica normal. Entonces, esas mujeres saben que hay una obstetra que viene una vez por mes a ese lugar y que va a dar atención. Eso las acerca. Cuando usted ya la capta, la puede filtrar hacia la clínica oficial o hacia el hospital y eso va a disminuir entonces lo que es mortalidad materna. También el poder ofrecer a las mujeres, como se dijo en algún otro momento, la posibilidad de disminuir embarazos no deseados, porque una forma vital para disminuir mortalidad es disminuir el riesgo de un embarazo que usted no quería. Usted es hipertensa, usted es diabética, usted es una adolescente que no quiere estar embarazada, pero no conoce de opciones. Entonces, ese puesto local es para que cualquier adolescente se pueda acercar y pueda decir, yo quiero información sobre métodos, yo quiero un método, yo quiero planificar. ¿Por qué resalto el trabajo con UNFA? Porque al trabajar con organizaciones que no sean meramente estatales como un todo, eso abre puertas a tener insumos que yo no tendría si estuviera nada más trabajando con mi jefatura real, que es la Caja Costarricense de Seguro Social, que tiene un sistema bueno, no estoy diciendo que no, pero aún así, eso no cubre a todos porque hay algunas cositas específicas que tenemos que trabajar. Entonces, el tener un puesto de salud al que yo llego una vez por mes, donde las mujeres me conocen, donde yo las conozco, donde se sienten cómodas, eso abre puertas para poder encontrar aquellas cosas que se deben de filtrar. Entonces, resumiendo, para no tomarme más tiempo del que se me otorga, ¿qué son las buenas ideas o las buenas prácticas que podríamos resaltar que está haciendo Costa Rica? Pues sí, crear mucha política, muchas estrategias, capacitar al personal, pero también abrir puertas, alianzas con otros que suman esfuerzo en la misma dirección. Porque si nos unimos y lo hacemos de una forma más ampliada, eso ayuda a que los que están quedándose atrás puedan ingresar en ese proceso. Y como vuelvo y digo, yo trabajo como obstetra, pero también soy afrodescendiente. Entonces yo sé, por ejemplo, que no es tan fácil que una mujer afrodescendiente busque atención en primer momento. Ella va a venir después de haber probado otras cosas. Entonces, si ella va a venir después de haber probado otras cosas, yo no puedo tomar como, es que vino porque es algo no importante lo que está pasando. No, yo tengo que pensar algo importante está pasando. Tengo que pensar en todas esas otras cosas que accesan, que uno llama aquí, que llama allá, que habla con ese, que habla con otro, en vías informales para que ella no se vaya sin la atención. Que esa adolescente que vino a buscar un método de planificación no se vaya sin una opción, porque va a regresar entonces con un embarazo de alto riesgo que va a ampliar o amplificar, se puede decir, el riesgo de una muerte. Entonces, tener aliados con quien trabajar proyectos facilita las cosas, definitivamente.
Yeah.
Siani, thank you so much for that. And again, you echoed what Monica said about partnership. Right. And the need for partnership to drive this change. I'm going to move swiftly on to bringing Carleen Wilson-Mitchell into this conversation, who's going to give us kind of an academic take on this as well, a research take. As I said, she's associate professor of midwifery at Toronto Metropolitan University. Carleen, the fact is we can't fix what we can't see. And we've talked about the data and how in many cases it isn't desegregated. Can you talk a little bit about that and how that is impacting the ability to achieve change, and what practical measures are being taken to address the data gap and enhance maternal health care for women and girls of Afro descent?
Thank you so much. That's a great question, Aisha, and to all of my panelists and colleagues here. It's a pleasure to be here. I have dual citizenship and have practiced midwifery for the last 32 years in both Canada and the United States. And I've done global health work within the Caribbean, sub-Saharan Africa. And I'm really grateful to be here. My doctoral research had to do with respectful maternity care, and it's one of the large infusions within our curriculum at Toronto Metropolitan University, that social justice, that health equity is important for us to take an active responsibility in. And midwives, as my colleagues has already explained, are advocates. We realize that we're in a broken system though. Canada, and I'm very proud of Canada, but we've made some interesting mistakes. We are the last industrialized country in the world to regulate midwives. Why is that? We're only about 34 years old in the midwifery profession. And we know that midwives have been advocates and system agitators, catalysts for change, because we try to change from within. We're not being co-opted by the system. We are entering the system and holding hands with our colleagues outside of the system, such as the doulas, those who are within the communities, community health workers, to change the system to respond to the clients it's supposed to be serving. And we're not doing such a great job. We're not even counting who we are caring for and what their outcomes are. In Canada, once again, the only industrialized country, we have an amazing healthcare system that is supposed to be universal, portable, accessible, but it isn't always. And the most vulnerable, as my colleague said earlier, end up being the canary in the mine. They're the ones who are the first to die. And it doesn't matter how well educated you are, how rich you are, how many allies you have. Serena Williams found out that she almost died because she dared to have a baby. Why should a leading Olympic athlete, educated Black woman, not be listened to, not be valued, not be heard? Why was Aisha, a leading journalist and celebrity, not listened to? Because somehow we are dehumanized, and everyone mentioned that very well. I appreciate Dr. Sumer for just framing it so nicely for us. We don't count, and therefore we are not counted in the statistics in Canada. We know the color of the blanket that covered someone as they were dying in an emergency room waiting to be cared for, but we don't know how much melanin is in their skin. Why? Because it doesn't matter in Canada, and because we're too polite to bring it up in conversation. Well, this Generation X, Generation Z, and the millennials that I teach, they're not waiting anymore. They want to change the system. I'm really privileged to be part of a collaboration, and collaboration is going to be needed because each one of us in this room has a different skill set. And instead of doing what the master did to the slaves, divide and conquer, we need to combine forces, not look at how differently we perceive the world, but all of our perceptions together give us a very acute vision of what's going on and how to fix it. So this coalition is one step towards solving some problems. In our research teams, and Dr. Julia Maraca is one of those researchers at McMaster University in Toronto that is looking at community-based participatory research where the methodology and how we collect the data and how we spread the knowledge and mobilize that knowledge afterwards is controlled by the people who matter. So she has a very diverse group of individuals. Some are policymakers, some are midwives as myself who are on the ground in the roots, and also educators, researchers. And we're realizing that our research was faulty, and even our quality assurance improvement was faulty because we weren't measuring the right things. We weren't even collecting the data the right way. So instead of always using the data that we have, we want to get even better methods of collecting the data and create data that actually has verifiable variables such as disability status, gender, race. And one of the presenters said before that it's not race that is causing the disparity, it is racism that is causing the disparity. It is intersectional oppression, multiplied exponentially oppression, so that it is changing us on the cellular level. Physiologically, we respond to environments differently, and we have worse outcomes than our white colleagues and peers and counterparts. And so having information that is contextualized is important. The way you gather the data is important. We know right now with the political situation going on right here in this country that numbers can be made to lie. We need clean data. We need truthful data. We need data that's maybe connected to census tracts, yes, but Canada has a very heterogeneous kind of population. In one corner, you'll have folks in various different income levels, various different races, various different religions, genders, they're all in the same apartment block. And so census tracts don't help us. We need to have things tied to maybe hospital discharge data. But what if the hospital discharge data doesn't include those who decided to have an out-of-hospital birth because they wanted respectful care in a birth center that was run maybe by one of my colleagues here, or have a home birth? Well, we're not collecting that data in our discharge data in Canada. So we're losing huge pockets of the Black population that decide not to go to the hospital for these very reasons. So we are working on solutions. The solutions have to maybe use a carrot and a stick. I heard the stick analogy. Penalize people for their obstetrical racism. Penalize them, show their bad stats for unnecessary episiotomies or non-evidence-based care. But maybe we should also give them an incentive. Maybe you get to relicensure or recertify in a state because you've done a certain amount of continuing education in how to avoid obstetrical racism or how to deliver high quality care. Because what we're realizing is that you actually have to teach that value. You have to teach humanization of birth, humanization of care, even have to teach how equity works, that it doesn't mean treating everybody the same. We have to unlearn a lot of what we learned in medical school or midwifery school or nursing school. We have to unlearn that and acquire a new set of luggage to go on this new journey. When I unpacked from going to Cuba, I had to unpack everything from Cuba and pack to come to New York. I needed a new set of suitcases. And that's what many of us are learning. We're hoping that we're not in an ivory tower university, but that we still have our feet on the ground with the grassroots. We're writing articles. We're coming up with economic models to show to our policymakers that treating people with respect actually costs you less money. It costs the system less to increase access, and that decreases our emergency room bill. It actually is not just being nice, it's economically sound. So maybe amongst all of us, as we're trying to knock on doors and push down walls, we're going to have to learn to use another kind of language. We're going to have to be savvy. Some of us are into behind the scenes, working behind the scenes, some are up front, but all of us are necessary. All of our identities, all of our skills and our talents and our gifts, they're necessary in this fight. And it's not a short scrimmage. It's a long-term war of attrition. And we need to keep each other. We need to hold each other up. We need to survive this war. It's not going to be over in a day or a year or a decade. I've been at this over 3 decades. I'm fighting the fight that my mother fought as a mental health nurse, where people were ignored in the emergency room and told to go home and die. Or you have a blood transfusion. These are real stories. My clients are telling me this. My colleagues, sisters, and daughters are telling me this. It's my story as well. People are being discharged after a blood transfusion to go home and die 2 hours later. People are told you're not in pain and then have an embolus. People are coming to visit their baby in NICU. Isn't that the right place to be, a level 3 leading tertiary care hospital? If you were going to have a blood clot, that would be the right place to have it, in that NICU visiting your baby. But no, they let her die. We have people who are high-powered, well-educated, they're ambassadors, they're representing our countries all over the world. They come into the ER and they're ignored. So those of us who are inside the system are trying to actually advocate every decision that's made. We are questioning it, examining it, and we are putting our licenses, our jobs on the line. That's what we're doing to make a difference.
Colleen, thank you so much. I can't thank you enough, everyone on this panel, for these great presentations you shared. I want to open up things now to the audience. We unfortunately have only a little bit of time because we're sensitive to how busy you all are, so I can only take 2 questions. If I could go with you, if you could say your name and your affiliation, please.
Sure. I'm Lori Edelman. I'm the ED for PP Global, and I want to thank everyone on stage for your contributions and for the work that you are doing for all of us. So thank you for that, and it was so nice to run into you earlier. I want to ask a question about our tactics and as a movement, and I'm using that word broadly. And it's a little bit nuanced, so please indulge me. I've seen the work of the Black maternal mortality crisis, and I've seen this be named a crisis, and for us to, in many ways, push politicians to respond to this crisis as a framework. And you just mentioned that this is not a scrimmage, this is not short-term work. And in the meantime, as that crisis language has grown, our indicators are not changing, and the numbers are not moving, and the stories are still coming out just as horrific. And in some ways, I've also experienced that crisis as dangerous. When I had my child, there was a poster on the wall that was all about Black maternal mortality. And as a Black woman, something that I experienced was a push towards a C-section just to keep me safe. And so that's just a nuance that I'm throwing into the room. And so I wanted to ask you about the term and the language and the moment of crisis, and what kind of framework you feel might be able to replace that might be healthier for our communities in the long term. Thank you.
Yeah. It's open to whomever wants to take it.
Can I answer that question by saying that we have to redefine safety? Cultural safety is a term that our Indigenous colleagues have used to help us frame safety, and we're going to have to inform people of what safe means. You probably weren't told of all of the complications that could come of a C-section, all of the scar tissue, the possibility of hemorrhage, nicking the bowels, the bladder, cystitis, all these other things. So we're not really being truthful when we say safe. What do you mean? Risks must be balanced with benefits.
Yeah. And I also think that when we think about So language is important. And when we use the word crisis, it puts people in a defensive posture, right? Which then, really shifts the way that care is provided. So I also want to insert the word care. Have we really thought about broadening what that really means and how we bring that word into the conversation? But I also think that one of the things that reproductive justice has also done is shifted the culture in the way that we talk about all of this together. And so even inserting just reproductive justice, you want to make sure that people feel like they have been seen, heard, taken care of in a particular kind of way. And so I also I don't want to take away from the fact that reproductive justice as a naming of a new way of talking about this has also supported kind of pushing back against kind of like the crisis narrative that again does put people in a deep defensive posture, which does impact the way that care shows up. Yeah.
Thank you for that. There was a second question and I can only take.
Sorry.
I'll take them. Oh, she has the microphone. So maybe I'll squeeze in a third one.
Hi, everyone. Thank you for the panel. Since everyone have the translation headset, I will speak in português. Okay. I am Andresa Jorge, eu sou Andresa Jorge, eu trabalho em uma organização no Brasil chamada Redes da Maré, que fica no Rio de Janeiro, num conjunto de favelas. Usually it's translated as shantytown or slum, but I like to use favela, called Maré. E a gente desenvolve um trabalho com uma comunidade de 140 mil pessoas, já há mais ou menos 20 anos. E uma das maiores dificuldades que a gente enfrenta na perspectiva de advocacy ou de incidência é que parece que os nossos problemas são sempre considerados muito específicos, são muito peculiares daquela área, mesmo falando sobre a questão da saúde de mulheres negras, ao qual, por exemplo, o Brasil tem como maioria a população de descendentes africanos. Então, um dos nossos maiores desafios é coletar dados, criar estratégias de coleta de dados, porque no Brasil nós temos um sistema de saúde universal e gratuito, mas muitas vezes os dados das pessoas que utilizam esse serviço não são racializados, não sabemos nem territorializados. Então, fica muito difícil ter números claros sobre essa discrepância entre mulheres negras e mulheres não negras. Então, eu queria muito ouvir sobre estratégias, pensamentos a respeito de coleta de dados e até mesmo compartilhar experiências positivas em diferentes territórios. Obrigada. Thank you.
Yeah. Thank you. Who wants to take that?
Yeah, you want to go first because you haven't spoken.
Yes,
yeah, you want to go ahead? Okay. Yeah, so one of the things I wanted to talk about was to help get some of those stories of those specific communities out. So one of the things that we did a couple of years ago was create this campaign called Trust Black Women. Right. And it was a campaign because there were all of these racialized attacks on abortion, in particular, that started in Georgia. And so we needed a counter narrative that gave Black women an opportunity to like really bring our voices together and bring our stories out around what was happening. And so that campaign has now grown to like really create like this powerful platform for Black women's stories, our voices across different movements to actually come into the conversation. And so it's a powerful frame, but I think the idea of creating a joined campaign or a joined message that really gives people something to zone in on really allows you to bring and extrapolate, right? Some of those stories and some of those experiences that you want from specific communities. And that was it was a powerful way for us at a time where it didn't feel like there was an opportunity for Black women to like really talk specifically to their experiences around abortion. Now, this is very specific to abortion, but it gave people a pointed way to bring those stories out. And it has now created this powerful platform for us to really uplift those stories. So that's just one example of like creating a campaign or creating a message that gives people a place to zone in on that then allows them to bring their stories in. And that worked really well for us and has created a national platform for us to do it. just one example.
Thank you for that. And I'm going to, I was going to squeeze in another question, but I'm getting the, I'm going to allow it. I'm going to, yeah.
Thank you all. Thank you for the first panel. Thank you, you guys. Questions. Refugee. There are people who are being left in all these conversations. I would like to know, what are you thinking as, for you, Monica, for your organization, what are you thinking of doing, or are you planning to have a partnership or going there? And for Colleen, if you would, you say you did work in Sub-Saharan Africa. If you have any data on refugee maternal health, that would be great. As a former refugee, that is something I advocate for.
Absolutely.
Thank you.
I will say very quickly, because I know we are very squeezed for time, this is actually a piece of our work that we're building muscle around, right? And there's someone in the audience, I want to direct you to Leah Jones, who's actually doing a lot of this work and building really powerful partnerships across our global connections, in particular around her work with fertility justice and birth justice, all the different things there. But it is a part of our movement that we're building a lot of muscle with. We're grateful to have this partnership with the Universal Access Project, because our biggest issue has been, how do we actually have the capacity and resources to build out this level of our work? And now we're doing that. So I think that we have some good things in place with some of the active programming that we're doing that Leah can tell you all about. And I'm down to talk more about some of the other global connections that we're making. But we're doing it. We're doing it. And we just had our national Let's Talk About Sex conference, which is the largest repro justice center conference in the country and in the US. And we had our first international delegation of folks coming into that conference. So again, the steps are there, and I'm really excited to connect with you after to talk about ways that we can strengthen that.
Thank you.
We have been doing quite a bit of research.
Sorry.
At our Center for Immigration and Settlement at the university. There is a lot of data. One of the studies I did several years ago looked at cesarean section rates, NICU admissions, postpartum hemorrhage. All of those had a higher incidence. So better research needs to be done. We're looking now at intersectionality, and we did a survey across Canada, and we're doing a deep dive on Black refugees and immigrants, and so far finding there's more abuse, less autonomy, things that we already expected to see, but we have the data that shows this now.
I will just say that thank you for that, Colleen. We are 7 minutes over, so I'm going to give each of you 30 seconds for closing thought. Can you do it? That's your challenge for the day. Monica, with you.
Okay, I'll say this one quote. Audre Lorde says that we cannot have single issue movements because we do not live single issue lives. To me, that has a global impact, right? And so we have to understand that our only pathway to liberation is through global solidarity, and that's what we have to make sure that we are making, that we're holding as the forefront and the guiding star to how we get to liberation. So that's what I want to say.
Amen. Siani.
Nada más decir entonces que siento que uno de los caminos para llegar a esto es el trabajo comunitario, trabajar con los niveles locales y con un trato sensibilizado y respetado, uniendo fuerzas con otras organizaciones para lograr la meta común.
If we really want to be equitable and right the unfairness and the wrongs that have been done, when we look at the disparities, we're going to have to start counting, and we're going to have to start being accountable for the care that we give. And there's a way for our communities to speak back to the institutions and the care providers, use those methods, complain, give your rating on the surveys. That's how they get funded. That's how, the news will get out about what they're doing and how well they're doing it.
Thank you so much. Monica Simpson, Siani Palmer, Colleen Wilson Mitchell, thank you so much. Please show your appreciation. And for me, thank you for being here today. And again, partnership. Thank you.
Thank you to our second panel. for such an insightful conversation, and definitely grateful for the extra couple of minutes there to have those questions. And I thought that was really important. Ladies and gentlemen, we have heard from several health experts this morning. We've been really challenged to accelerate our efforts to remove barriers, as well as develop and scale up approaches that end racism and sexism. And we must also strengthen access to high quality maternal health, including maternal health service delivery. Through these panels, we heard a couple of things that I just wanted to touch on quickly. We heard about intersectionality. We heard about meeting people where they are, ensuring that there is verifiable data in our communities, and most of all, that we are not only getting that data, but hearing the real stories behind them. So I'm really grateful to everyone who has shared those real stories today, because in sharing those real stories, that's how we get the news out there. Of course, that's how you get to folks like myself who have the opportunity to tell these stories. And we're always really grateful when people trust us to tell a part of their story, because it's certainly time for a drastic shift in our approach to reaching the most marginalized and the furthest behind. And as echoed several times today, the time for action is now. So that's why we are all here. I am pleased to invite Ms. Diane Keita, Deputy Executive Director of Programs at UNFPA, to join us here at the podium once again to mobilize us to action as she briefly unveils some of the objectives of the Global Coalition for Building Transnational Solidarity and Action to Bridge the Gap in Afro-Descendant Maternal Health. Welcome once again to the podium, Ms. Keita. Thank you.
Thank you so much, Melissa. I'm going to close at the same time my part, since I will not talk anymore. Excellencies, mi preferida excelentissima. Friends, partners, and colleagues, please allow me to ask you to please applaud everyone who has spoken today. Immense respect to you all, because what you do is just amazing. And Melissa, I do not agree with you. You are a star all by yourself. And of course, my goodwill ambassador is as well. So thank you to both of you for being here with us. You know, listening to you, it's important. And before launching this, almost at the same time last year, the Minister of Foreign Affairs from Costa Rica came, we had this discussion. No, it was during the ICPD celebration, actually, this discussion on how to support better Afro-descendant women and refugees women and women transiting within the country. They were working on it, but they were asking us, how can we do differently? How can we do together and better? Just to say that government are thinking about it. You know, government are thinking about it. The US, exactly the same thing. I've attended meeting here in New York with the Washington Post that are just amazing. The city of New York has $2 billion dedicated to this. And I can go on and on and on this. But of course we said it's not enough. It's never enough. We are 8 billion of us around the world. But thank you for what you do. Be blessed, all of you, and let's continue to walk and walk the talk. So that being said, I'm really delighted to launch the Global Coalition for Transnational Solidarity and Action to bridge the gap in maternal health for women and girls of African descent. The coalition is dedicated to addressing the urgent need for global action to prevent maternal death among women of African descent. Our goal at UNFPA is to join all of you, as you heard here today, in the effort to tackle the structural inequities that undermine maternal health outcomes and overall well-being of women and girls of African descent. In the coming month, the coalition will host a series of global consultative workshops designed to foster collaboration among national government. They are so critical. They are so important. Civil society organizations, cities, academic institutions, private sector, and healthcare professionals and communities of African descent to ensure the way forward and co-creating together. What we aim at is to scale up the support to enhance the collection of analysis and dissemination of globally comparable maternal health data, targeted policy and intervention for strengthening health system and addressing biases and racism in service delivery. What we have heard today is not possible. Imagine the women who cannot access what we can access in this room. And enhance community participation and representation to improve the involvement and representation of community of Afrodescendent in maternal health decision-making and service delivery. We look forward to working with all of you. We look forward to working better and stronger. I heard people talking about what PAO is doing, what they need to have a UN Women, but UNICEF, whatever you take at UNHCR, we need everyone. Of course, the work you do at the UN Foundation is so important, Terry. So thank you so much for being here. We need to get to the last mile together. The last mile can be very far in some countries. And the last mile in some country can be in the middle of New York City. Yet it can be very far, So how to get to the last mile, it's important. But why we need to get to the last mile is because everyone counts. The Summit of the Future is up to a great start with this forum here today. I thank you all and bless you all. Thank you.
We need to get to the last mile together. I want to thank you, Ms. Keita, for giving us a snapshot of what the coalition's work will focus on. And for more information about it, you can contact bgmhc@unfpa.org. Once again, that is bgmhc@unfpa.org. We are so delighted that we have several member states who have responded to this important call to action. So I have the pleasure of inviting Her Excellency Ambassador Mariam McIntosh, Permanent Secretary for Foreign Affairs of the Ministry of Foreign Affairs, International Business, and International Cooperation of the Republic of Suriname, to deliver her statement. And I just want to ask our audience, this has been such a rich conversation. So please, if you have 10 more minutes of your time for us to just get through these important statements from our member states. So I want to invite Her Excellency Ambassador McIntosh to the stage to deliver her statements.
Oh, thank you, moderator. And I would not want to keep you from your lunch, so I will be brief. Organizers and co-sponsors, fellow co-sponsors, I see one of my dear friends that I know from way back. Dear friends all, we as Suriname, we are happy and delighted to have joined this group. And I have to say, sitting here, having listened to the passionate stories of the ladies in the back here, we are definitely convinced that as governments, partnerships, as you mentioned, and partnerships at all levels are important. So that is the general that I would like to keep here. And then I would like to go quickly to only the Surinamese situation, because I know you have heard a lot of great things of the people standing before me. So I would not want to belabor the point, but speak specifically to maybe the challenges faced within Suriname. And we know that the Latin American and Caribbean region is one of the regions that is quite multicultural, but yet when we check the data, and I think it was also mentioned before, we know that there are a lot of challenges when it comes for people and women of Afro-descendant women and preventing childbirth related deaths. In Suriname, and I know many of you know, we have a quite diverse society, not only Afro descendants, but people from
all over the world. We call it ourselves a mini UN. We do speak Dutch. I know someone said goedemorgen this morning, but still the challenges for Afro-descendant women remain. And in particular for the women living in the interior, and we spoke about social determinants of health when it comes to education and access to health. Access to health, for instance, in the most remote areas where you have the majority of people of women of African descent living is also challenging because you have to bring that primary health care to the women. And that is the challenge many of them face. And then we have definitely high mortality, maternal mortality, and also morbidity in those places. But the government is not sitting still. We have as one of our priorities policy and legislative measures on addressing and advancing maternal and newborn health. We have developed a maternal and neonatal health strategy and also an operational plan. And we have launched recently a pilot perinatal information plus system. And definitely it could not have been without the support of our partners, PAHO, WHO. Because we know as a government, you can do as much, but definitely the support of PAHO, WHO, not only PAHO, WHO, also the civil society, the people on the ground making a difference. We should not forget that civil society is important in supporting what governments are doing. So that's why we feel that, and I was also mentioned the issue of the availability of reliable data. That is for us important. And maybe I have to say, because of our multi-ethnicity, we collect data desegregated by ethnicity. So you know that we have, because of our demographics, you cannot say you don't collect data based on ethnicity, because it is important when you have policy interventions that you know exactly that this is, you have this specific data and you have specific targeted measures towards each and every one of the people in Suriname. And we are happy, Deputy Executive Director, to join and support the Global Coalition for Building Transnational Solidarity and Action to bridge the gap in Afro-descendant maternal health. And we know that we can do great things. We look forward to further activities and hopefully also to partner with UNFPA, PAHO, and all other people here in the room, but also with governments, the governments who are here, but also other governments. We hope that we can partner all with them. But thank you so much for indulging me.
Thank you so much, Ambassador McIntosh. Next, it is my distinct pleasure to invite Her Excellency Ambassador Maritza Chan Valverde, the permanent representative of Costa Rica, to present her remarks.
Morning, everyone. Costa Rica has proudly joined this coalition for transnational solidarity to champion an intersectional, culturally relevant, data-driven, and holistic life course approach to advancing maternal health and justice for women and girls of African descent. Last year, when UNFPA published a report, Maternal Health of Women and Girls of African Descent in the Americas, we learned about the intensity of the gaps in maternal mortality between Afro-descendant women and those who are not, reaching out to 3 times higher number of deaths during pregnancy, giving birth, or after delivery. And this is just a proxy to reality. The lack of quality data only is showing us the tip of the iceberg. However, the data that we have is enough to understand that this is unfair, preventable, and that we can change this situation now. In response, Costa Rica has started a series of campaigns founded in the first decade, international decade for people of African descent, the ICPD, the Nairobi Program of Action, and we will revamp our national policy at eradicating discrimination, racism, and xenophobia with a new strategy to be released this year. The opposite of discrimination is inclusivity and equity. And inclusivity, as Siani said, starts at the local level. La inclusividad, Siani, como usted nos contó, empieza a nivel local. And what Siani has done really well in Limón, one of our provinces, is working with women, not only of African descent, she's working with women who are transnational indigenous women. And this shows that it is not only culturally relevant, but it's an example of intercultural solidarity that we must recognize and applaud. Costa Rica has a social security system that is universal. And as a result of the universalization of our healthcare services and the implementation of these intersectional and intercultural approaches, Costa Rica's maternal mortality rate dropped by almost 60% between 2000 and 2020. These achievements underscores the effectiveness of integrating primary healthcare principles into universal health coverage, and most importantly, to take action. So my friends, I'm very happy to be here. Thank you for raising awareness. Thank you for asking for more data. What is not measured is not seen. And it's time to make these women, our women, visible. I'm also a woman of color. And it's important for me to realize that as part of another community, we are seen and we are heard. The opposite of discrimination is inclusivity, and enough of that. Thank you.
Thank you, Ambassador. Next, I welcome to the podium His Excellency Ambassador Juan Jose Quintana, Deputy Permanent Representative of the Permanent Mission of Colombia.
I'm the old man out, it appears. Muy buenos días a todos. Me complace mucho estar aquí. Me honra mucho que mi país esté en la primera línea entre los que apoyan esta coalición. Debo confesar que este evento ha sido muy interesante para mí. Ustedes no saben la cantidad de cosas que tiene que atender el segundo de una misión en Nueva York. Este pasó rapidísimo porque el tema fue fascinante y las presentaciones, los testimonios que escuché me dejaron aterrado. Creo que el momento es perfecto para este tipo de iniciativas para la coalición. Yo tengo aquí un libreto que prepararon los expertos de mi misión, lo voy a leer con mucha disciplina para que no me regañen, pero quería mencionar al comienzo que la presente coyuntura es perfecta para un país como Colombia porque hemos asumido el rol de estar a la vanguardia en el tema de la situación de niñas y mujeres afrodescendientes. Hace menos de un mes Colombia unió fuerzas con el Brasil y logró en la Asamblea General de la ONU la aprobación de una resolución fijando el 25 de julio como el Día Internacional de la Mujer y la Niña Afrodescendiente. Esperemos que en los próximos años esta fecha sea utilizada como ancla para hacer eventos sobre estos temas que afectan directamente el bienestar y la salud de las mujeres y las niñas. La coalición que presentaron hoy y que nos estamos uniendo es un paso claro hacia la concreción de esfuerzos para lograr la meta de 0 muertes maternas. Los logros del Fondo de Población y de los esfuerzos conjuntos de los estados tienen un indicador concreto, que es la cantidad de vidas salvadas. Y los datos nos muestran la urgencia y magnitud del problema. Creo que quedó muy claro en las presentaciones de hoy que las mujeres afrodescendientes se ven desproporcionadamente afectadas por las desigualdades estructurales e históricas y enfrentan un mayor riesgo de mortalidad materna, además de tener una tasa sustancialmente menor en acceso y calidad de servicios de salud, un desafío que debe movilizarnos a todos hacia la acción inmediata. En estos contextos quisiera resaltar el rol de la partería tradicional en un país como Colombia, donde ha sido clave en la atención materna en muchas comunidades locales. Las parteras no solo brindan atención médica esencial, sino que lo hacen desde un enfoque culturalmente inclusivo que entiende y respeta las particularidades de cada comunidad. Esta forma de atención, la partería, profundamente enraizada en el conocimiento ancestral, crea la confianza y seguridad fundamentales para el bienestar materno y neonatal, especialmente en contextos rurales, marginados o apartados. Habíamos construido antes una falsa dicotomía entre la salud moderna y las prácticas tradicionales para la atención a las madres y neonatos. Ahora sabemos que tejer puentes entre ambas es clave para atender las necesidades específicas de mujeres afrodescendientes y mujeres habitantes de espacios rurales. Un ejemplo muy concreto de esta práctica es el proyecto Partera Vital, que conoce muy bien UNFPA en el departamento del Chocó, en Colombia, integrando la partería tradicional con los servicios modernos de salud, proveyendo a las parteras y parteros con tecnología para que puedan identificar factores de riesgo y señales de alarma, prever posibles complicaciones, realizar remisiones oportunas de las gestantes y registrar a los nacidos en partos asistidos en forma tradicional. Proponemos, por lo tanto, que el rol de la partería sea reconocido y potenciado institucionalmente como una herramienta clave para la reducción de la mortalidad materna y la implementación de soluciones libres de sesgo, discriminaciones y violencias. Más allá de la dimensión de salud, las premisas en las que se basa la coalición son una evidencia clara de la importancia de reconocer que ciertos grupos poblacionales son particularmente vulnerables a formas múltiples e interseccionales de discriminación. Por todo esto, Colombia se enorgullece de impulsar iniciativas como esta y de unirse a la coalición en su primera línea. Muchas gracias.
Thank you so much, Ambassador. And I think one thing that sticks out in my mind is ensuring that we're meeting communities where we are and that importance of community care and this partnerships as we've been talking about. Next, we have a video message from Ms. Lois Pace, Assistant Secretary for Global Affairs of the USA Department of Health and Human Services.
Good morning, colleagues and partners. Though I was not able to join this critical convening in person, I am pleased I could join you virtually to share U.S. government's commitment to this coalition, formed to build transnational solidarity that bridges the gap on maternal health for women and girls of African descent. I'm proud to join my esteemed colleagues from other member states and our civil society and multilateral partners to reiterate our commitment to health equity and addressing sexism and racism in health systems. Maternal mortality is a key indicator of health and socioeconomic development. It is a reflection of an entire national health system and represents the outcome of its successes and shortcomings while illuminating issues around transparency and disparities. Unfortunately, we all know the staggering and frankly unacceptable statistics. In the US, Black women like me are 3 times more likely to die from a pregnancy-related cause than white women. Around the world, Afrodescendent women and girls are 3 to 4 times more likely to die from preventable maternal health issues compared to white women. Here at the Department of Health and Human Services in the US, we are taking unprecedented action to close such disparities and strengthen Black maternal health. We've invested over $470 million to reduce maternal mortality and morbidity by expanding coverage, implementing new policies, and providing funding to ensure safer pregnancies and postpartum services for new parents and their babies. Our new policies have made it possible for almost every state in the nation to expand postpartum care to 12 months for women with lower incomes. And yet there's still much more to do. For example, we still need more and higher quality data. The lack of racial and ethnic disaggregated health data contributes to an incomplete picture that does not capture the poor maternal health outcomes for Afrodescendent women and girls. High quality, disaggregated data is crucial for effective policymaking and building political will to address structural racism and sexism in health services. This links to a broader conversation the world should be having about sexual and reproductive health and rights, reducing maternal mortality and morbidity, empowering individuals to have the knowledge, services, and supplies to decide if and when to expand their families and access safe abortion. So we welcome the creation of this important coalition dedicated to enhancing the maternal health and well-being of women and girls of African descent. Becoming a parent should be one of life's joys, and pregnancy and childbirth should be a dignified and safe experience for everyone. We will continue to advance the Biden-Harris administration's commitment to ensuring equitable access to health care before, during, and after pregnancy for all mothers in our country and around the world. Thank you, and best wishes for an impactful meeting today.
We want to thank Ms. Pace and the U.S. Department of Health and Human Services for that message. It is now my pleasure to welcome Ms. Viviane Rios Balbino, Minister, Counselor of the Permanent Mission of Brazil, to deliver remarks.
Thank you, moderator. Boa tarde a todas e a todos. Buenas tardes. Good afternoon. Thank you to all the incredible panelists. And I would like first to congratulate the organizers for promoting this crucial debate as the UN is ready to agree on a pact for the future. Because there's simply no future for humanity without the reproductive work done by women. Despite this basic fact, we know that unfortunately the rise in maternal death is a worrisome tendency in many parts of the world, including my own. It is also regrettable that this increase was caused in many countries by the rise of deaths among Black women. Just last week, the government of Brazil launched a new program aimed to reduce mortality among expectant mothers, especially Black mothers, honoring Aline Pimentel, a low-income Brazilian Black woman who died 6 months pregnant at the age of 28 in 2002, leaving her 5-year-old daughter an orphan. The Aline case was brought to the CEDAW committee, and the recognition that her death from preventable causes is a violation of human rights drove the government to name the new program after her. Brazil's priority at the moment is to reduce the race gap in terms of maternal mortality in our universal healthcare system, the Sistema Único de Saúde, that covers all types of healthcare for all residents and visitors, including undocumented people. Currently, Black women face twice as much risk of dying from pregnancy and birth-related complications than white women. Indigenous women are also at a higher risk. Among the actions to combat such inequities are tackling institutional racism, boosting prenatal and primary care programs after their defunding in recent years, improving coordination between services, and investing in monitoring. With the new Aline Pimentel program, Brazil aims to reduce mortality for Black women by 50% by 2027 and to achieve the SDGs mark of 30 deaths per 100,000 live births by 2030. Brazil thanks UNFPA for cooperation in this crucial area and stands in solidarity with partner countries in this coalition, especially in our region, to tackle racial disparities so that all pregnant women can enjoy good health and give birth to healthy children. We do also wish for all girls to have a chance to grow to become full adults before they take on the responsibility of raising another human being. And I thank you.
Thank you so much, Ms. Balbino. We will next hear from Laure Berg, First Secretary, Permanent Mission of the Grand Duchy of Luxembourg, to deliver remarks.
Excellencies, colleagues, friends, it is an honor to join you today for the launch of the Global Coalition for Transnational Solidarity and Action to bridge the gap in maternal health for Afro-descendant women and girls. Luxembourg is proud to support this initiative, which aligns with our commitment to global health equity and ensuring that no one is left behind. The disparities in maternal health outcomes for women and girls of African descent are a profound injustice. Without targeted action, achieving our goals for reducing maternal mortality and promoting health for all will remain out of reach. Maternal deaths are preventable, and we must act now to safeguard the highest attainable standard of health for Afrodescendant women and girls worldwide. Protecting the rights of women and girls and empowering them to reach their full potential is central to Luxembourg's development cooperation efforts. We are actively addressing barriers to quality care for Afro-descendant women and girls, not only through flexible multi-annual funding to UNFPA, but also through a specific regional project in Central America and the Caribbean. This project aims to reduce adolescent pregnancy and to address the deep-rooted issues of racism and discrimination. By focusing on empowering Afro-descendant communities, this initiative shows the transformative potential of collaborative action. I am hopeful that the global coalition launched today will serve as a powerful platform for solidarity, evidence building, and the scaling up of effective maternal health strategies across borders. Luxembourg looks forward to contributing to the coalition's success. Together, we can bridge the gap in maternal health and create lasting change. I thank you.
Our thanks to Luxembourg. Last, I call to the podium Ms. Gabriela Madero Jimenez, gender expert, humanitarian affairs, Permanent Mission of Mexico to the UN to deliver remarks.
Thank you so much. And I would like to say on behalf of Gabriela, her apologies, she couldn't be here today. My name is Megan Diaz, and I'm a gender advisor at the Mexican Mission. Well, to begin, I would like to start by thanking the UNFPA for inviting Mexico to co-sponsor this event. Muchas gracias. And as the distinguished panelists today have emphasized, Afrodescendant women face significant disadvantages in maternal health, a situation that demands urgent action and makes the launch of the Global Coalition today not only timely, but essential. Before discussing the coalition more in detail, I want to briefly share Mexico's national context. Understanding that, as we have said today, what cannot be measured cannot be improved, and what is not recognized cannot be addressed, Mexico prioritized including Afrodescendant women in both our legal framework and our national statistics. Indeed, for the first time in 2020, the national census of our country included the category of Afrodescendants. Thanks to this, we know that 3.1 million people in Mexico identify as Afro-Mexicans, 51% of whom are women. Moreover, our Constitution now recognizes Afro-Mexican peoples and communities, ensuring their self-determination and autonomy. However, as we have discussed today, this is just the beginning. There's still much more to be done to ensure that no Afro-Mexican woman or girl is left behind. And I say this just because 10 years ago in our country, we didn't even have these statistics. We didn't have this recognition. So once again, there's much more to be done. We lack this vital data. And even today, Afro-Mexican women have limited access to safe abortions and sexual education. Just to illustrate, in municipalities with over 70% of Afro population, the average number of children per woman is 3.3, which is significantly higher than the national average of 2.1. In the face of these disparities, systemic change, as we talked about it and some of the panelists mentioned, that's what we need. It's not only necessary, it's urgent. And that is what we are promoting today with the launch of this coalition. Today is thus a day of hope in international cooperation, of hope in multilateralism, and of hope for millions of Afro-descendant women and girls whose lives are endangered simply because of who they are and for the lack of opportunities that they have had. In this regard, Mexico, as a country that elected its first ever woman president, and a country that has an intersectional feminist foreign policy, we stand firmly for the sexual and reproductive health and rights for women in all their diversity. And in this spirit,
Mexico fully supports the launch of this coalition and remains committed to the promises made in 2015 to leave no woman or girl behind. Muchas gracias.
Thank you to all of the member states who have delivered remarks on this really important coalition and the launch today. As we prepare to end, I invite you to turn your eyes once again to the screen for closing remarks from Dr. Kaleng Mofengeng, United Nations Special Rapporteur on the Right to Health.
As a medical doctor, a practicing clinician, and a Black woman myself, I know firsthand what it means to be a Black woman in need of critical healthcare. And this topic of bridging the gap in maternal health for women and girls of African descent is particularly important for me as a clinician, but also as a woman, because I know how my human rights, when they're respected, promoted, protected, I'm able to enjoy many other of my human rights and develop and be a full human and experience life in all of its promise. However, we know that the legacies of colonialism and enslavement, including racism, sexism, and exploitation, continue to disadvantage many of us through our life cycle. Maternal mortality among Afro-descendant women and girls is a global crisis that demands urgent action. The intersection of racism and sexism within health services limits their access to quality, accessible, affordable maternal and sexual and reproductive health care, ultimately depriving them of dignity and violating their basic rights to the highest attainable standard of physical and mental health. And through the work that I've been undertaking at the Commission for O'Neill and Lancet Racism and Structural Discrimination and Global Health Commission, we have also uncovered that the maternal and sexual and reproductive health needs of Afro-descendant women and girls can only be addressed by tackling the root causes, confronting structural racism and sexism and discrimination that underpin health disparities, because we know that these compounding negative outcomes are not as a result of individual genetic predispositions. There are systems of power at play, and therefore, to tackle the disparities in maternal health among women and girls of African and African descent, it's crucial to acknowledge, interrogate, and understand how extensive the history of abuse and rape and disregard that they have endured and continue to endure is. In many of my work as a special rapporteur during country visits, technical visits, and of course through the different calls for contributions, it continuously comes through that the legacy of mistreatment, disrespect often persists in health systems and clinical care, resulting in voices of Afro-descendant women and girls being silenced, their cultural and health needs being completely ignored or even mocked. The systemic nature of the neglect contributes to these very high levels of maternal birth-related injuries and as well as death. As we move forward to try and think, how do we tackle this issue? It is about understanding that racism is a key determinant of health. It transcends borders and it can be stopped. It is critical that we approach the disparities with an intersectional framework, understanding that it's through systems of power that make privilege for some and make disadvantage for others. And so understanding that this is about power, how do we then achieve health outcomes we aspire to as a global community? We must then first adopt universal health coverage and primary healthcare models to guide how we provide services. We must address structural, social, commercial determinants of health together with these health systems models. We must also ensure that we have disaggregated data that can influence policy, redesign and shift where budgets are being made and allocated. We must ensure that the data has enough detail and quality in it that can be also used by civil society, by Afro-descendant communities themselves to advocate and to hold their own leaders accountable. Data collection must be done respectfully and ethically as well. We know that throughout the world, preventable maternal deaths are continuing. Any part of the world, global south, the so-called global north, Black women are consistently at a higher risk of preventable maternal deaths, with rates 3.7 times higher than those of white women. And so it is imperative that member states take on the right to health approach, prepare national policies, prepare national budgets to support those national health policies. Bring on technical, good experience from international organizations and healthcare workers, and include civil society and leaders and midwives and the communities themselves to bring this urgent change, to change the status quo. We cannot do this alone. And investment in communities is key and crucial. Midwives save lives. We need more of them from these Afro-descendant communities serving the Afro-descendant communities. I commend UNFPA, PAHO, and all of the co-sponsors for their dedication for enhancing cooperation, increasing investments, and to fostering essential solidarity to accelerate meaningful change. And I continue to be available and continue to put my mandate forward as a special rapporteur on the right to health to do all that I have within my working methods to help you improve maternal health outcomes for women and girls of African descent. And I wish all of you luck and look forward to engaging with you in this important work going forward.
We thank Dr. Mofengeng for adding her voice to the call to action for this and for those important and insightful remarks. I think that she summed up a lot of the things we talked about really well today. Ladies and gentlemen, you have been part of a historic day towards bridging the gap on maternal health for women and girls of African descent. Thank you so much for your time and attention. On behalf of the co-organizers and the co-sponsors, we thank all of our speakers, our technical team, interpreters, volunteers, for all of your contributions to this successful event. And to you, our audience, whether you're here in person or you have joined us online, for your continued commitment to this work. Once again, I'm Melissa Noel. It's been an honor to be your MC today. Bye for now. To everyone, have a fantastic day. Thank you.